Yes, there's one question.
No, only one question. There are several questions. Thank you very much. In spite of the fact that Sunday morning we have heard 3 beautiful, nice presentations. So I will start with a second one, the mimickers of the stroke. I'm afraid that you haven't mentioned one very important. It's a subacute or chronic occlusion of a middle cerebral artery. I have had 3 such cases. If you have, for example, the patient that is found on the floor, for example, and the CT shows subarachnoidal bleeding, aneurysm, which is suitable for treatment, and occlusion of middle cerebral artery. What is the pathology? What is the structures that should be treated first? Aneurysm or middle cerebral artery, especially if you have only clinical picture and CT angiography without CT perfusion. I have 3 such cases, and in 2 cases I saw very, very good collateral flow, and I decided to treat only the aneurysm with very nice result. In one case, we did not have any records, previous images. We did not anything about the patient. And then I tried to recanalize.
Can we let them answer, please?
Yes.
Yes.
No, please.
I mean, if you have two problems in the same patient, I think you should target the one that it's the acute one. I mean, if I understood correctly, it was subarachnoid hemorrhage in patients that had a decreased size of even occlusion of the MCA, yes. And it was an MCA aneurysm?
It was
you have to open the MCA to go to the aneurysm?
So you can wait a little bit with the treatment of aneurysm, but you cannot wait with the treatment of occluded MCA.
But it was a ruptured aneurysm? I didn't get it.
Yes, it was a ruptured aneurysm.
Well, I'm not sure about. You want to comment?
And there was an occlusion of M1?
It was occlusion of N1. It was occlusion of M1. So the question is, okay, if we have a CT perfusion showing the typical image, and if you can see that the perfusion is completely normal, we know that we should treat the aneurysm first. But if we don't have CT perfusion, we don't know what was the first, occlusion or rupture or both, maybe. So my point actually is, if we have, since in the 3rd case I didn't finish, I tried to recanalize, I felt some resistance in N1, I stopped that attempt, called the aneurysm, and CT that was performed after the treatment showed a small hematoma. So I was lucky and the patient was lucky. So my conclusion in those 3 cases, if you have a patient with ruptured aneurysm, subarachnoidal bleeding, and completely occluded or occluded MCA, it's much better to send patient back to CT and perform CT perfusion.
Okay, thank you very much. I think there may be more questions regarding the CTA and MR applications. What is your preference for? I noticed when we change from CT to MR, we have much less mimickers than when we stay with CT. This is my impression when we heard the lecture from Professor Villilia. So when you have a CT angiography, is there anything you particularly ask for? You need to see the entire circulation over the brain, or you restrict to the basal arteries?
I don't have MR for acute stroke patients.
Okay.
So I don't know about the rest of the people in the room, but I don't have MR for acute stroke patients, so I have a protocol with CT. So CT with the low, it starts with a low dose protocol just to rule out hemorrhage, and then go to CT perfusion and then CTA from the aortic arch to the vertex.
Yes.
And you wonder, should we also study the heart? That's something that, because you may see a thrombus, but I don't think, I mean, probably it's not worth it. So we do from aortic arch to vertex studies. So unfortunately, I don't have MR available, but you have?
Yeah. No, we have MR available. I show the protocol we use, and to me, I think with MR we have more chance to depict stroke mimics indeed, and to eliminate stroke mimics. And although we have a better chance to see the ischemic lesion, I agree that it's not so simple to organize things to have MRI available on a regular basis, on a 24-hour basis. But we have to. I think it's for stroke. It's quite important to do it.
Yeah. Thank you very much. I think we have come to the end of the session. I'd like to thank the audience in particular for the attention, and I'd like to thank the speakers for their excellent presentations. Don't forget to put the CME stickers on your evaluation form, and thank you very much.